So the next statement is that the 33-year-old man presents to the emergency department with a gunshot injury to the abdomen. At laparotomy, a deep laceration is found in the pancreas that is left of the vertebral column with severance of the pancreatic duct. So it shows that this is a major pancreatic duct injury and that is one of the reason for going for the laboratory. So what is the question asking now? So what is the next step in the management? So would it be intraoperative phalangogram, debridement and drainage of the defect, distal pancreatectomy, closure of the abdomen with JP drain, or vagotomy? So as this is a pancreatic injury question and it is showing that the pancreatic duct, the main pancreatic duct is involved. In that case, it is a high grade injury of the pancreas and it is dealt with distal pancreatectomy. So distal pancreatectomy is the procedure of choice for distal pancreatic injury, especially to avoid creation of the intestinal anastomosis because pancreatic anastomosis are at a high risk of development of pancreatic fistula. That is why they are avoided. And if there is a need of an intraoperative pancreatogram, it is only required to rule out proximal duct injuries. But as we have already established with the eyes that there is a main pancreatic duct injury, so now the management would be distal pancreatectomy. So pancreatic injury is divided into low grade and high grade. Low grade injury, that is 1 and 2, it does not involve the pancreatic duct. But if the pancreatic duct is involved, it becomes a high grade injury. Low grade pancreatic injury is managed non-operatively with letting the patient enfield, serial examination, labs, and nasogastric decompression. However, if there is involvement of pancreatic duct, then surgical management is the mainstay. So it is also done when the patient is unstable, if there is pancreatic duct injury or there is a peripancreatic hematoma. So what is done in the surgical management? So if the proximal pancreas is involved, then debridement with drain placement will be the management. Pancreatoduodenectomy or temporary closure followed with later on reconstruction. However, if there is distal pancreas being involved, then distal pancreatectomy plus minus penectomy is the treatment of choice. So the next statement is, there is a 40-year-old man, he is hit by a car and sustains injury to the pelvis. So which of the following is most indicative of urethral injury? Will it be hematoma, scrotal ecchymosis, oliguria, high riding prostate on DRE, or intravenous pyelography showing dye extravasation in the pelvis? So the most indicative of urethral injury in scenario of a pelvic trauma is high riding prostate on a digital rectal examination. So a high riding prostate on rectal examination is an indicative that the urethra has been torn and the prostate rides up with the bladder. However, the definitive study for suspected urethral injury is a urethrogram, and inability to void and a crushed pelvis also raises high possibility of a urethral injury. The important thing is that other options are likely to occur, but as they have asked that the most indicative, in that scenario we will be selecting high riding prostate on rectal examination. So this question is related to the above question. For the patient described in the previous question, urine did not extend to the leg because the membranous layer or the Scarpa's fascia is fused inferiorly with. This is an anatomy question, so we should be clear about that. With which part of the fascia the membranous layer is fused? Is it the femoral sheath? Is it the fascia lata? Is it the femoral fascia, the deep inguinal ring, or the superficial inguinal ring? So the answer is the fascia lata. So urine may extend into the subcutaneous layer of the anterior abdominal wall and scrotal scale. However, fusion of the Scarpa's fascia, which is part of the superficial fascia, with the fascia lata, on which is otherwise known as a deep fascia, it will not allow the extension of the urine down the thigh. So this is an anatomy based question, and we just need to remember that the membranous layer or the Scarpa's fascia is fused with the fascia lata. This fusion is going to prevent the extension of urine into the thigh. So the next question is, a 70-year-old man is brought to the emergency department following a car crash. X-rays reveal a fractured rib on the left side and a fracture of the right femur. CT scan of the abdomen is showing left-sided retroperitoneal hematoma adjacent to the left kidney. There is no evidence of urine extravasation. How should the hematoma be managed? By observation, exploratory laparotomy, CP-guided aspiration, surgical exploration through left flank retroperitoneal approach, or pneumatic anti-shock garments. As this is a hematoma around the kidney and there is no sign or red flag symptom present, then in such scenarios, any hematoma is managed with observation or conservative measures. So a small non-expanding hematoma with no associated urinary complication or extravasation is managed with conservative followed with repeat CT scan and ultrasound. However, in the scenario that you are monitoring the patient and they become hypotensive, then there is an indication for exploration. So renal injuries present with hematuria, and it is one of the best indicator of renal injury, but it does not predict the severity. Again, as other investigation of choice in renal injury is CT scanned with contrast, and it will be showing us hematoma, perinephric hemorrhage, or laceration, transaction, or any other type of renal injury. It is a rule of the thumb that all renal injury patients should be managed conservatively with serial hemoglobin, signs of hemorrhage, serial scans, and if there is hypotension or signs of hemorrhage via embolization. However, there are certain indications for surgical management which include persistent hematuria, urine extravasation, bilateral kidney injury, hemodynamic instability, that is one of the very important indications, or a high-grade injury to an already isolated kidney due to any other reason. So what are the surgical options? We can repair it, go with unilateral nephrectomy or partial nephrectomy. To have a much better understanding, I would suggest that kindly listen to this renal injury lecture in the handwritten trauma series so that you can have a better concept about all the isolated discuss injuries and their classification. So now we have a 60-year-old man who is hit by a pickup truck and presents to be emergency with a blood pressure of 70, means that he is already in class 4 shock. Peritoneal lavage showed no blood. The blood pressure is elevated to 85 systolic after 2 liters of Ringer. However, X-ray has shown a pelvic fracture. This is a pelvic fracture scenario in which the patient is hemodynamically unstable. So what is the next step in the management? Would it be exploratory laparotomy, CT scan, external fixation, or exploratory laparotomy with bilateral ligation of the internal IA vessels? So in this scenario, the best option would be application of external fixator to the pelvis. So early external fixation of the pelvis has been shown to reduce bleeding as well as mortality in shock consequent to pelvic fractures. An unstable patient should never be sent for any CT scan. Selective angiography with embolization can be helpful but only in selected patients. And laparotomy usually worsens the condition because around 70 to 80% or even more of the pelvic bleed is venous and it is very difficult to identify it and stop it. So in pelvic trauma scenario, the very first step is to provide pelvic binder followed by external fixation. I will explain this with a flow chart as well. So pelvic fracture management flow chart. So the management of hemodynamically unstable patient is stabilization of the pelvis with pelvic binder in the trauma room or the first responder scenario. However, it is followed by external fixation. If both these fail, then embolization, and once the embolization has failed, then we perform a lower midline laparotomy through the preperitoneal space and perform packing of the vessels. Even in that scenario, ligation of the vessel is very difficult, so only packing is taken care of. So next up we have an 18-year-old man is brought to the emergency after falling from a flight of stairs and losing consciousness for 3 minutes. So that is very important. A cervical collar is in place, a cervical spine considered to be free of serious injury following which procedure. So what should be done to this patient so that we can make sure that the cervical spine is free of injury? So what is the next best step in the management of this patient? Would it be physical examination, a lateral cervical spine x-ray, completely negative findings on neurological examination, epilateral and odontoid views of the neck, or flexion and extension views of the neck? So in order to rule out complete cervical injury, we have to go with the epilateral and odontoid views of the neck in terms of x-rays to completely identify the patient free from any cervical spine injury. So flexion and extension types are rarely indicated and must be performed with careful supervision. However, negative findings on physical exam alone are not reliable in a patient who has an impaired sensorium. So next up we have a 16-year-old boy rehearsed to the emergency with a stab wound in the anterior mid-neck. On physical examination, it is difficult to determine if the plane of the platysma has been violated or not. However, subcutaneous emphysema is found on palpation. So what is the next step in the management? Would it be going for an esophagogram, going for an arteriography, surgical exploration, esophagoscopy, CT scan of the neck with oral and high contrast? So the important thing is that a stab wound in the mid neck needs surgical exploration. So mid neck, that is defined as the zone 2, stab wound whenever happens in there, it requires surgical exploration specifically if there are 2 points, either presence of subcutaneous emphysema or an expanding hematoma. Zone 2 midline lesions are those between the lower border of the mandible and the hyoid bone. Let me explain this with the help of a diagram. So we have divided neck into 3 zones. So the first zone is from the cricoid to the clavicle, and the zone 2 is from the cricoid to the angle of the mandible, and then from the angle of the mandible to the base of the skull is zone 3. In any of these zones, the first step is to go with a CT scan and followed with angioembolization. Now, in 1 or zone 3, angioembolization is the treatment of choice specifically for unstable patient. However, if there is an unstable patient and it is a zone 2 injury, then surgery is the mainstay of treatment. So next up we have a 28-year-old woman who presents to the emergency after being hit in the face during a baseball match. On physical examination, the patient's blood pressure is 90 mm mercury and there is significant bleeding from the nose that cannot be controlled either by fracture reduction or by anterior and posterior nasopharyngeal packing. So this is a scenario of nasal bleed and quite a number of options have already been evaluated and still it has not resulted in control of the hemorrhage. So what will be the next step in the management? Would it be external carotid artery ligation, bilateral internal maxillary artery ligation, angiographic evaluation followed with embolization, polycac balloon, tamponade bleeding control, or insertion of the neurogastric tube? So in this scenario, angiographic evaluation followed by embolization is going to be the next step in the management. So because it is not possible to identify the specific vessel injured by just physical examination, angiography with embolization is going to be the go-to treatment. Insertion of an NG tube in patient with mid-facial trauma should be avoided because it can result into a false passage into the brain. So now we have a 65-year-old male who is brought to the hospital after being hit by the car. His blood pressure is 150 by 90 millimeter of mercury and the pulse is 120. There is a deformity just below the left knee. So there is a deformity over there, and along with that, there is no distal pulse palpable. Plain X-rays are showing proximal tibia and fibula fracture. So what is going to be the next step in the scenario? Would it be operative intervention, angiography, Doppler ultrasound, or operative reduction, or heparinization? So as there is no distal pulse and the patient's vitals are stable, so in that scenario, it will be better to go with the angiography before going with the operative. So if in this similar scenario, the patient is hypotensive, then we will go with the operative intervention to restore the blood. But as the patient is having no pulse, yet he is stable, that is why we're going to go initially with the angiography to identify the specific pathology and to see for the waveform that is identified on the angio. So in a stable patient presenting with peripheral vascular injury following a blunt trauma, angiography is indicative to identify the operative approach. An angiogram can also document any pre-existing atherosclerosis, presence of collaterals, and the basal runoff. Doppler ultrasound is useful to localize the injury, but it gives a little bit less information as compared to angiography. So that is why angiography is a better option as compared to Doppler. Immediate control of bleeding is indicative if the patient is unstable. So if you have a good concept about that, what is the management when the patient is stable and when the patient is unstable, it is very less likely that you will wrong any MCT. So a 70-year-old man is brought to the emergency following his injury as a passenger in a car crash. He complains of right-sided chest pain. Physical examination reveals respiratory rate of 42, that means he is tachypnic, and multiple broken ribs of a segment of the chest wall that is moving paradoxically with respiration. So what should be the next step? Would it be tube thoracostomy, tracheostomy, thoracocentesis, endotracheal intubation, or intercostal morphology? So as this patient is having flail chest, the next best step in this scenario would be to perform a thoracocentesis. So thoracocentesis should be performed as first to rule out tension pneumothorax or presence of hemothorax. However, if the patient does not respond rapidly, then early intubation is necessary with a flail segment because the patient due to pain will be unable to take proper breath, and those shallow breaths will eventually result into buildup of carbon dioxide. So in that scenario, that even chest tube has not responded to the patient, then they require endotracheal intubation. So intercostal nerve block and other means are useful to control the pain, but they are not useful to identify or manage the respiratory problem which are going to be of great concern.